Welcome to the IPNA online educational series for general practice nurses. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing the topic of osteoporosis. Osteoporosis, commonly known as the silent disease, is characterized by low bone mass and structural deterioration of bone tissue, leading to bone fragility and an increased risk of fractures. It is estimated that 300,000 people in Ireland and approximately 200 million people worldwide are affected by the condition. Osteoporosis is the most common metabolic bone disease in Ireland and increases the risk of fragility fractures. Fragility fractures occur mainly at the hip, vertebrae, and distal forearm and are associated with significant morbidity, mortality, and reduced quality of life, attributed not only to the fracture itself, but to the high prevalence of comorbidities in this patient population. The prevalence of osteoporosis is expected to increase significantly in the future because of population aging. Osteoporosis is the most common bone disease worldwide and a major public health hazard with high morbidity, mortality, and socio-economic costs. Osteoporosis mainly occurs in postmenopausal women and elderly men. A postmenopausal woman's annual risk of fracture is greater than her combined risk of cardiovascular disease and breast cancer. 1 in 4 men and 1 in 2 women over the age of 50 will develop a fracture due to osteoporosis in their lifetime. The disease can also affect children. 20% of people aged 60 and above who sustain a hip fracture will die within 6 to 12 months due to secondary complications, and 50% of people over the age of 60 who sustain a fractured hip will lose their independence. Only 15% of people in Ireland are actually diagnosed with bone loss, leaving an estimated 280,000 people undiagnosed. Let's now look at the signs and symptoms of osteoporosis. A fragility fracture occurs when a person sustains a broken bone from a force less than or equal to that sustained from a fall from a standing position. With severe osteoporosis, even forces as minor as a cough or a sneeze or turning over in bed or lifting a small weight can result in a fracture. Another symptom is the development of a kyphosis. A stooped posture where the person's head is bent forward may result from an anterior wedge fracture of the spine. In severe cases, a dowager's hump may develop on a person's upper back, which is a strong indication that osteoporosis should be considered. Another symptom is loss in height from 2 to 16 centimetres. Height loss greater than 2 inches is an important sign of an asymptomatic vertebral fracture and should be evaluated for osteoporosis. A person can lose height due to wear and tear of vertebrae or their discs, but greater than 2 inches is unusual in degenerative joint and disc disease. Another sign is change in body shape or size associated with loss of height. A distended abdomen can develop as the stomach and intestines push outward, followed by the rib cage resting on the pelvis. These changes can cause difficulty in breathing, back pain, depression, loss of functional independence, and GI symptoms. And another symptom is sharp, sudden pain in the low, middle, or upper back. Especially with height loss, this should be evaluated for vertebral fractures, as this may be the first presentation of an osteoporotic fracture. When plain films are normal and symptoms persist, repeat x-rays several weeks later or additional image may show a fracture. Causes of back pain should always be addressed and vertebral fractures must always be ruled out. Osteoporosis is multifactorial in origin. It occurs when there is an imbalance between new bone formation and old bone resorption. Bone turnover is regulated by the interaction between osteoblasts and osteoclasts. Osteoblasts form new bone, and osteoclasts are responsible for bone resorption. Both types of cell are under hormonal regulation. Up to 90% of peak bone mass is acquired by age 18 in females and age 20 in males. The amount of bone mass in the skeleton can keep increasing until a person reaches their late 20s, at which point bones have reached their maximum strength and density, known as peak bone mass. As people age, the rate of bone resorption by osteoclast cells exceeds the rate of bone formation, so bone weakens. The greatest cause of osteoporosis is estrogen deficiency, which results in increased bone turnover in which resorption exceeds formation. Corticosteroids can also induce osteoporosis, in which trabecular bone is particularly affected from suppression of osteoblastic activity. Peak bone mass is the major determinant of adult bone density. Peak bone mass has a strong genetic component, with between 60 and 85% of the variance in bone mineral density being attributable to genetic factors. Certain risk factors are linked to the development of osteoporosis and contribute to an individual's likelihood of developing the disease. Some risk factors are modifiable, while others are not. So let's now have a look at some of the modifiable and non-modifiable risk factors in osteoporosis. So the modifiable risk factors include the following. The reduction of estrogen levels in women at menopause is a strong risk factor for developing osteoporosis. Men have a gradual reduction in testosterone levels as they age. Treatment for prostate cancer that reduces testosterone levels in men and treatments for breast cancer that reduces estrogen levels in women accelerate bone loss. Too much thyroid hormone can also cause bone loss, and this can occur in hyperthyroidism or if too much thyroid hormone medication is used to treat an underactive thyroid. Osteoporosis has also been associated with overactive parathyroid and adrenal glands and hypogonadism. Long-term use of certain medications such as glucocorticoids and some anticonvulsants can lead to loss of bone density and fracture. Depo-Provera contraceptive has been proven to cause bone loss, particularly high risk if given during adolescence when bone is being laid down. Another modifiable risk factor is an inactive lifestyle, which can lead to weakened bones and increased risk of osteoporosis. Cigarette smoking and excessive consumption of alcohol also increase the risk of bone loss and fractures. Dietary factors increase the risk for osteoporosis. Low calcium and vitamin D intake contributes to diminished bone density, early bone loss, and an increased risk of fractures. Eating disorders, severely restricted food intake, low BMI, and being underweight weakens bone in both men and women. Non-modifiable risk factors include gender. Women are much more likely to develop osteoporosis than men. Women have less bone tissue and lose bone faster than men because of the changes that occur with menopause. Age is also a non-modifiable risk factor, and the risk of developing osteoporosis as bones become thinner and weaker increases with age. Body size is a non-modifiable risk factor. People who have smaller body frames tend to have a higher risk of developing osteoporosis because they have less bone mass to draw from as they age. Ethnicity is also a non-modifiable risk factor. White and Asian women are at highest risk. African American and Hispanic women have a lower but significant risk also. And genetic is a non-modifiable risk factor. A family history of osteoporosis is a very strong risk factor. People whose parents have a risk of fractures also seem to have reduced bone mass and may be at greater risk for fractures. Let's now look at how osteoporosis can be diagnosed. Osteoporosis is a silent disease without obvious symptoms until a fracture occurs. Bone turnover biomarker detection can be useful in monitoring osteoporosis treatment and assessing fracture risk, but not for diagnosis of osteoporosis. Osteoporosis can be diagnosed by the presence of a fragility fracture, measurement of bone mineral density, known as BMD, and bone biopsy, which is a diagnostic procedure restricted to untypical, unclear, and complicated cases. Bone biopsy is not routinely used and should never be undertaken without consultation with a specialist in osteoporosis and metabolic bone disease. All people presenting with a fragility fracture after 50 years of age or menopause should be considered as possibly osteoporotic. A detailed history of the fracture occurrence, physical examination and evaluation for other fractures is carried out, while noting any presence of back pain, kyphosis and height loss. Baseline laboratory tests include full blood count, serum chemistry levels, liver function tests, thyroid stimulating hormone level, 25-hydroxyvitamin D level, serum protein electrophoresis, 24-hour urine calcium creatinine, testosterone, and luteinizing hormones. Additional testing should include measurements of bone mineral density, known as BMD, and if there is height loss and/or back pain, imaging of the spine. On average, BMD is lower in women than in men. Women have smaller bones and smaller trabeculae. Women, as they go through the menopause, lose more bone in their lifetime than men, 50% in females compared to 35 to 40% in males. The fracture risk assessment tool known as FRAX is a prediction tool for assessing an individual's risk of fracture in order to provide general clinical guidelines for treatment decisions. It has been adapted by the Irish population using estimates about life expectancy and fracture incidence in Ireland. The Irish FRAX tool has been calibrated using national hip fracture incidence data and Irish mortality rates. FRAX computes the 10-year probability of a hip fracture or a major osteoporotic fracture. 8 identifiable risk factors shown to improve the prediction of fracture risks are included in FRAX, and these are age, family history of hip fracture, glucocorticoid use, current smoking, alcohol use, and rheumatoid arthritis. Individually, the presence of these risk factors are shown to increase the risk of hip fracture at least 1.5 to 2-fold after adjustment for bone mineral density. FRAX has some limitations as it only accepts one risk factor, while many cases of osteopenia and osteoporosis have multiple risk factors which can significantly increase their risk of fractures. A DXA scan is used to measure bone mineral density of the spine and hips, which helps to assess the risk of bone fractures. DXA scans are most commonly used for diagnosing osteoporosis and assessing the risk of osteoporosis developing. BMD is mainly described as T-score, which represents the standard deviation number by which the BMD in an individual differs from the mean value expected in young healthy individuals. T-scores should only be used in the diagnosis of adults over 21 years of age. The World Health Organization's criteria for osteoporosis is a bone mineral density that lies 2.5 standard deviation or more below the average value for young healthy women. Above -1 standard deviation is normal. Between -1 and -2.5 standard deviation is classed as osteopenia. Below -2.5 standard deviation is classed as osteoporosis. DXA also provides the patient's Z-score, which reflects a value compared with that of a person's matched for age and sex. Z-score should be used in premenopausal women, men younger than 50 years, and children. Z-score values of -2 standard deviation or lower are defined as below the expected range for age, and those above -2 standard deviation as within the expected range for age. Osteopenia is the early stage of osteoporosis and places a person at risk of developing osteoporosis. The Irish Osteoporosis Society divides osteopenia into three categories. Mild osteopenia is a T-score of -1 to -1.49 and usually requires lifestyle changes. However, causes should be investigated and addressed. Moderate osteopenia is a T-score of -1.5 to -1.9, which usually requires lifestyle changes. Causes should be found and addressed, and the person may require medication depending on the cause or if they have a fragility fracture. Marked osteopenia is a T-score of -2 to -2.49, which requires lifestyle changes. Causes should be found and addressed, and the person may require medication depending on the cause or if they have had a fragility fracture. Osteoporosis is treatable and fractures are preventable. The primary goal of therapy is to reduce the risk of fractures. A comprehensive treatment program includes a focus on nutrition, exercise, and safety issues to prevent falls that may result in fractures. In addition, medication to slow or stop bone loss, increase bone density, and reduce fracture risk may be prescribed. Treatment for each individual is based on their risk of fracture or refracture, causes of osteoporosis, age, DXA scan results, and medical history. Assessment of bone markers before and at 3 and 6 months post commencement of treatment gives an earlier indication of the response to treatment. All postmenopausal women and individuals at risk of osteoporosis should be encouraged to maintain a healthy weight, ensure adequate calcium, vitamin D and protein intake, and avoid excessive alcohol consumption and smoking. Calcium and vitamin D are essential for the prevention and treatment of osteoporosis. Bone is a major store of calcium and phosphate, and every body cell requires calcium. Vitamin D helps to regulate cell growth and the immune system and is essential for the absorption of calcium. Vitamin D increases the body's ability to absorb calcium by 30 to 80%. Vitamin D is the only vitamin required by the body that does not have to be consumed through food or supplements, as it is manufactured through the skin when exposed to sunlight. Supplements are generally only recommended when the daily amount of calcium and vitamin D from dietary sources are not being met. Many people, however, do not get the recommended amount of vitamin D through food or sunlight, and supplements are often recommended. In Ireland, the recommended dose of calcium is 800 micrograms per day for children, adults and older people, increasing the dose to 1,200 milligrams for teenagers, pregnant and lactating women. The National Osteoporosis Foundation in the USA recommends 1,000 to 1,200 milligrams of calcium and 800 to 1,000 international units of vitamin D for adults aged 50 years and older. This chart, produced by the Irish Nutrition and Dietetic Institute, shows the recommended daily allowances of calcium and vitamin D for babies, children, and adults. The richest sources of calcium in the diet are milk, cheese, and yogurt. 3 servings a day help meet the calcium needs of an adult or child, and 5 servings are recommended during adolescence and pregnancy. Smaller amounts can be obtained from leafy green vegetables, bread, and sardines. The bioavailability of calcium from non-dairy sources is lower, and foods fortified with calcium and vitamin D can be useful. Vitamin D is primarily produced by the action of UVB sunlight on skin. Oily fish, egg yolks, liver, and fortified dairy products also provide vitamin D. Due to Ireland's northerly latitude and the use of sunscreens, vitamin D production from UVB light is compromised. Together with poor dietary intake, this has contributed to widespread suboptimal vitamin D status. Low vitamin D status is prevalent in Ireland, particularly in postmenopausal women. Dietary sources should be encouraged in all ages. Calcitrol is a vitamin D analogue licensed for the treatment of established postmenopausal osteoporosis. Patients should have serum calcium and creatinine monitored for hypercalcemia. Malnourished adults, particularly those with an inflammatory condition, are at increased risk of bone loss. Particular attention should be paid to the calcium intakes of individuals at risk of osteoporosis due to conditions such as celiac disease, malabsorption, or inflammatory bowel disease. Estrogen replacement for women going through the menopause can help to maintain bone density and reduce fracture rates while they are on treatment. There is a direct relationship between the lack of estrogen after menopause and the development of osteoporosis. Early menopause before the age of 45 and any long phases in which the woman has low hormone levels and no or infrequent menstrual periods can cause loss of bone mass. Estrogen therapy and estrogen with progesterone hormone therapy are approved for the prevention of osteoporosis in postmenopausal women, provided there are no contraindications. HRT is not suitable for people who have a history of breast cancer in their families, particularly in early menopausal patients or patients who have had a history of deep vein thrombosis. Selective estrogen receptor modulators, known as SERMs, work in a similar manner to estrogen on bone by preventing bone loss in postmenopausal women who do not have hot flushes and provided there are no other contraindications. It is used for the prevention and treatment of osteoporosis in postmenopausal women and to reduce risk of invasive breast cancer in postmenopausal women at high risk or with osteoporosis. Evista helps to maintain bone density and reduce fracture rates specifically at the spine. It is administered as a 60 milligram tablet once daily. Evista can be taken with or without food or drink and at the same time as calcium and vitamin D supplements. Appropriate weight-bearing exercise is also necessary. Denosumab, brand name Prolia, is a monoclonal antibody which binds to rank ligand, inhibiting the maturation of osteoclasts and therefore protecting the bone from degradation. Prolia is indicated for the treatment of osteoporosis in postmenopausal women and in men at increased risk of fractures. In postmenopausal women, Prolia reduces the risk of vertebral, non-vertebral, and hip fractures. Prolia is also indicated for the treatment of bone loss associated with hormone ablation in men with prostate cancer at increased risk of fractures. Patients must be adequately supplemented with calcium and vitamin D. The recommended dose of Prolia is 60 milligrams, administered as a single subcutaneous injection once every 6 months into the thigh, abdomen, or upper arm. It is the first choice of drug for those at high risk of hip fractures or those who have had a hip fracture over the age of 75 with T-scores of less than minus 2.5 at the femoral neck or with a humeral fracture. Bisphosphonates, also known as anti-resorptive medications, are non-hormonal drugs which help maintain bone density and prevent further bone loss. Boniva, Fosamax, Fosavance, Actonel, and Aclasta are potent inhibitors of bone resorption and mainly increase the BMD of trabecular bones. Biophosphates are poorly absorbed from the gastrointestinal tract. They should be taken alone or on an empty stomach first thing in the morning with at least 250 ml of water. After administration, the patient should not have food or drink or medications or supplements for at least a half an hour. Other treatments for osteoporosis include parathyroid hormones. Parathyroid hormone brand name Preotac is a bone-forming agent that stimulates the formation of new bone, and it's administered as a daily 100 microgram dose subcutaneous injection in the thigh or abdomen for 24 months. It can only be prescribed by a consultant for severe osteoporosis and is contraindicated with patients with cancer. Patients need to have follow-up tests done at 1, 3 and 6 months for elevated serum or urinary calcium. The patient should then have a repeat DXA scan, and a new treatment plan should be implemented at the end of the course of treatment. Parathyroid hormone, brand name Forcio, is a recombinant human parathyroid hormone 1 to 34 and a bone-forming agent that stimulates the formation of new bone. Foresto can only be prescribed by a consultant. It is given as a daily 20 microgram subcutaneous injection in the thigh or abdomen for 24 months. The patient should then have a repeat DXA scan and a new treatment plan implemented at the end of the course of treatment. PTH is usually recommended for those with severe osteoporosis or fractures and those who cannot tolerate other medications. Forsteo can help with the pain of vertebral fractures and the reduction of vertebral and non-vertebral fractures in women. Surgical treatments for osteoporosis include kyphoplasty and vertebroplasty. Kyphoplasty is a surgical treatment involving a balloon being placed into the fractured vertebrae, followed by bone cement being injected into the balloon. Vertebroplasty is a non-surgical treatment involving a needle with bone cement being inserted into the fractured body of the vertebrae under imaging guidance. The decision to perform these techniques is made by a multidisciplinary team to ensure that this is the correct approach to managing the collapse. Many of the consequences of osteoporosis, particularly vertebral fractures, are associated with severe pain. Patients with established osteoporosis should be treated for pain relief and physiotherapy offered for the secondary effects of osteoporosis. Pharmaceutical and non-pharmaceutical measures can be used to alleviate pain. Patients should be advised of all their options and encouraged to try different approaches until they find what works best for them. Forsteo and proteolos can help with the pain of vertebral fractures. Proteolos has a dual action. It reduces bone reabsorption, prevents bone loss, and increases bone formation and bone mineral density through formation of new, strong bone. Prevention of osteoporosis should ideally start in utero. Childhood and teenage years are critical periods for the development of strong, healthy bones, especially before puberty and between the ages of 8 and 12 years. If good peak bone strength is achieved in early childhood, the risk of osteoporosis in later life is reduced. The Irish Osteoporosis Society recommends that from birth throughout life, everybody should receive the recommended daily allowance of calcium and vitamin D. The Irish Osteoporosis Society aims to increase awareness and significantly decrease the number of people affected by osteoporosis in Ireland. They aim to establish a network of local awareness groups, and they provide support, advice and information for people with osteoporosis, and they distribute up-to-date information to healthcare professionals on current methods of prevention and treatment and encourage research in this area in Ireland. The role of the practice nurse in the prevention and treatment of osteoporosis is very important. Assessment and treatment can be well managed in primary care settings. Practice nurses play an essential part in the delivery of quality primary care, and they have a growing responsibility in the screening, assessment, treatment, and management of long-term conditions, including osteoporosis. A holistic, person-centered approach is required in the management of patients with osteoporosis, providing ongoing assessment, management, support, and education. Key roles are establishing a therapeutic relationship with the patient, assessing the patient's understanding of their condition, establishing goals and expectations for successful management of the patient's condition, and evaluating the physical, emotional, and psychological effects of the condition on the patient's well-being. Assessment, monitoring, audit, and evaluation for disease activity, progression, and the effects of the therapeutic regime on a patient with osteoporosis is a continuous process. By implementing person-centered care, monitoring and evaluating symptoms, outcomes, and responses to therapy, practice nurses play a pivotal role in managing the illness and improving the patient's quality of life. This is a list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on osteoporosis, which is part of an online educational series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA. Thank you.